Good morning, teacher. Good morning, friends. My name is Roberto Guevara, and I'm going to talk about crystallopathies. Okay, deposits of crystals, misfolded proteins, or airborne particulate matters of nanoparticle or microparticle size, which of all are the hereafter referred to here as crystal deposits, can cause diverse medical disorders that can manifest as either acute or chronic organ injuries. Recent discoveries in the study of crystal biology suggest that unifying pathophysiological mechanisms can underlie these disorders and may identify molecular targets for the innovative therapies. In nature, organisms catalyze the aggregation of atoms and ions into amorphous crystals, which are built into complex structures such as corals, shells, bones, and teeth. These structures can provide the structural stiffness and durability. In the wrong place, the same process can be injurious. For example, calcification of the vascular walls or tendons. The aggregation of these atoms and ions in a periodic manner can lead to a self-perpetuating growth of the regular shaped crystals. Single crystals sticking together or glued together by semen-like amorphous crystals can form polycrystalline masses such as calculi, like in the renal calculi.
So what does the normal look like in joint fluid aspiration? Color, it should be colorless or straw colored. Aspect or clarity, it should be clear. Consistency, thin and stringy. Viscosity, moderate. White blood cells, less than 200 white blood cells per cubic millimeter, and the neutrophils or the PMN should be less than 25%. Red blood cells, 0 to 1, free of bacteria, fungi, or viruses. Glucose, slightly lower than that of the blood. If the diagnosis is uncertain, examine the synovial joint. Poke that joint and tap it, get the fluid, send it to the lab. Joint fluid examination is diagnostic in cases of infectious arthritis and microcrystalline arthritis. We say microcrystalline, don't expect to see like a 4-carat diamond ring inside the patient's big toe. It's not going to happen. Never pass the aspiring needle through an underlying plaque of psoriasis or cellulitis. You can transmit infection. If the patient is on anticoagulants, use a small gauge needle to decrease the risk of bleeding. Do not aspirate of the INR, which is part of the prothrombin time. The international normalized rate is higher than 3 because there is a higher risk of bleeding. We're trying to diagnose the disease, not kill the patient. Now you tap the joint and send the fluid to the lab. What will the lab do? 4 things. Gross examination by the naked eye. I always laugh at naked eye. Cell count, you count the cells. Microscopic examination, and then cultures to detect infection. If you didn't know that cultures are supposed to detect infections, there is no hope for you. This is not sociology, this is medicine. So when you examine the joint fluid by your eye, the aspect or the clarity, it should be transparent. That's normal. If it's mild inflammation, translucent, which is different from transparent, if you noticed. Opaque, purulent, this is inflammation. This is septic arthritis. Bloody in cases of traumatic tap, trauma, bleeding disorders such as hemophilia. Bleeding into big joint is a sign not of the primary hemostasis problem, but the secondary hemostasis problem, because this is a deep bleeding. There's a problem in the coagulation factors, not the platelets. When we count the white blood cells per microliter, also known as cubic millimeter, also known as MCL, same stuff. Normally less than 200, non-inflammatory less than 2000, so osteoarthritis is here. Inflammatory 2000 to 75,000, so rheumatoid arthritis is here. Purulent is more than 100,000, septic arthritis is here. Microscopic examination by the plain polarized light. Negative birefringent, the monosodium urate in cases of gout. Positive birefringent cases of pseudogout called calcium pyrophosphate dihydrate crystals. The gram stain should help with septic arthritis, but it's only 50% sensitive, which is a piece of trash because this is just like flipping a coin. Now let's play this game. Here is osteoarthritis. Okay, please now leave the couch. Don't be lazy. Your butt is becoming one with the couch. Leave the couch, sit on a disc, get a piece of paper and try to answer all of the upcoming questions. We're talking about osteoarthritis. I want you to guess how the clarity will be. How about the color in case of osteoarthritis? White blood cells, PMNs, and culture of the joint fluid aspirate. Now pause. The answers. Clarity should be transparent. What was the normal? The normal is transparent, so this is normal. Color. In osteoarthritis, it's yellow. Do you remember the normal? Colorless or straw colored. So this is kind of darker than normal. White blood cells, less than 2000. Do you remember the normal? Less than 200. PMNs, less than 25%, which is normal. Culture is negative, which is also normal. So your main problem here is the white blood cells. The second problem is the yellow color. But mainly don't forget the white blood cells, less than 2000. Let's talk about rheumatoid baby. Again, clarity, color, white blood cells, PMNs, and culture. Now pause. Welcome back, people. Okay, rheumatoid arthritis is an inflammatory arthritis. So the clarity, translucent to opaque. Is this normal? No, it's not. What's the normal? The normal is transparent. Color, yellow to opalescent, which means multiple colors. Is this normal? No. What was the normal? Colorless. Okay, let's go to white blood cells. 2000 to 75,000. This is inflammatory. Is this normal? No. What was the normal? Less than 200. PMNs, greater than 50%. Is this normal? No. What's the normal? Less than 25%. Culture, negative. This is inflammatory. There is no infection. There are just crazy autoantibodies. Oh.
Okay, applications in medicine. The shared pathological mechanisms of crystal-related and microparticle-related disease may provide new therapeutic targets. Inflammation-mediated may release often interleukin 1B, which was validated as a pathway common to most of the diseases discussed here, through the demonstration of the protection from inflammation and injury of the NLRP3 deficient mice, familiarization and inflammation and injury by interleukin-1 agonist therapy in mice and humans. These drugs can suppress interleukin-1 related inflammation, including the interleukin-1b neutralizing antibody canakinumab, the fusion protein of interleukin R1, and the human IgG renalized, and the recombinant human interleukin 1R antagonist anakinra. Canakinumab was provided in Europe as a treatment for a recurrent gouty arthritis on the basis of its capacity to rapidly suppress inflammatory pain in gouty arthritis and prevent some further gouty attacks. In addition, A1 antitrypsin Fc fusion protein can abrogate interleukin 1 driven inflammation in gouty arthritis.
Let's talk about gout, baby. I mean, look at this big toe. Big toe, but doctors don't say big toe, they say first metatarsal joints because doctors are super sophisticated to the point of being stupid. Okay, anyways, gout, again. Okay, pause. Here are the answers. It's exactly the same as rheumatoid arthritis. Okay, clarity, translucent to opaque, which is not normal. Color, yellow to opalescent, which is not normal. White blood cells, 2,000 to 75,000, which is not normal because the normal was less than 200. PMNs, more than or equal 50,000, and the culture is negative. Okay, let me ask you a question. How about microscopic examination in cases of gout? Would you expect negative birefringence or positive birefringence? And the answer is negative birefringence. Can you describe the shape of the crystals? Yes, they are needle-like. Malar rash that involves the cheeks, the nose, but spares the nasolabial fold. In a female in her childbearing age, this is probably lupus. What kind of autoantibodies can we see? Anti-double-stranded DNA, anti-Smith antibodies, anti-U1RNP antibodies, and anti-ribosomal P proteins. How about the complement level in the plasma? Low, called hypocomplementemia. Now pause. Alright folks, lupus is an inflammatory arthritis, so same exact thing as gout and rheumatoid. Clarity, translucent to opaque, which is not normal because the normal is transparent. Color, yellow to opalescent, which is not normal because the normal is colorless. White blood cell, 2000 to 75,000, which is not normal because normal is less than 200. PMNs, greater than or equal 50%, which is not normal because the normal is less than 25%. Cultures are negative because there are no bacteria. This is normal. Next, Sjogren syndrome, a triad of dry eyes, dry mouth, and inflammatory arthritis. You have an increased risk of lymphoma. What kind of lymphoma? Is it Hodgkin's or non-Hodgkin's? The answer is non-Hodgkin's. Which subtype of non-Hodgkin's? And the answer is marginal zone B-cell lymphoma, also known as multoma. Watch my video on marginal zone lymphoma if you wish. Cool, now pause. Okay, here are the answers. Sjogren syndrome is an inflammatory arthritis, so treated exactly the same as rheumatoid, lupus, gout, etc. Clarity, transparent to opaque, which is not normal because the normal is transparent. Color, yellow to opalescent, which is not normal because the normal is colorless. White blood cells, 2000 to 75,000, which is not normal because the normal is less than 200. PMNs is abnormal, the normal is less than 25%. Cultures are negative. The video is not over yet. I'm just letting you know that I have Perfectionalis Ultimate Notebook, also known as PUN, about lymphoma. All you need to know about lymphoma in a very huge file, more than 90 pages, more than 100 megabytes. Plus, I'll give you 20 lymphoma cases with answers and 25 bleeding cases with answers, available at the current price only for 50 students, so hurry up please. Now, septic arthritis, which is a medical emergency, affects usually one joint. It's a monoarticular problem. Now, pause. So this is the worst. It's purulent. Not just inflammatory, it's purulent, which means severe inflammation and infection. Clarity, opaque, which is worse than translucent. Okay? What's the normal? The normal is transparent. Color, yellow to green. What's the normal? Colorless or straw-colored. White blood cells more than 100,000, which is huge, which is abnormal. The normal is less than 200. PMNs, more than 75% of the white blood cell count. This is crazy. Culture is positive, usually. Why positive? Because there is a bacteria. Hello. So here's the table that will summarize everything for you. Now forget about volume. This is kind of BS. Let's talk about the clarity. Normally transparent, non-inflammatory, transparent, inflammatory, translucent to opaque, purulent, opaque. How about the color? Normally should be clear, colorless, non-inflammatory, yellow, inflammatory, yellow to opalescent, and purulent, yellow to green. White blood cells, normally less than 200, non-inflammatory, less than 2,000, inflammatory, 2,000 to 75,000, purulent, huge, more than 100,000. Then PMNs, normally less than 25, less than 25, inflammatory, more than 50, purulent, more than 75%. Culture, negative, 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 positive, usually. Okay. So, normal is here, osteoarthritis is here, rheumatoid arthritis is here, Sjogren here, lupus here. How about purulent? This is the septic arthritis, baby, including gonococcal arthritis. Thank you so much for watching. Please subscribe to my channel and save my rheumatology playlist. Please support this channel on Patreon. You will get the cases, you'll get the notes, you'll get lots of great stuff. So thank you in advance, and this is Medicosis Perfectionalis. As always, be safe, stay happy, and study hard.
Okay, pros and cons. I just found cons. Deformity and joint injuries. If you have a chronic gout, you'll have swelling in your joints on a regular basis. Chronic inflammation and thrombus can lead to its deformity, softness, and permanent joint damage. In the worst cases of a chronic gout, you may need surgery to repair these injuries and replace some joints. The kidney stones. If you have gout, you have a risk of developing these kidney stones, as ureate crystals may build up in your urinary tract and form stones. Renal disease and renal failure. Kidney stones formed by the ureate crystals may build up in your kidneys, which can cause injuries and scars. This kidney damage from this ureate crystals accumulation is through the lead to kidney disease over and over time, especially if gout is not treated.
So gout is a joint disease that actually doesn't have much to do with the joint, in the sense that the joint is fine, but it's a deposition of something that doesn't belong in the joint that causes all our problems. I'm drawing it on the big toe here because that's where gout is most commonly located, and it's been described as one of the worst kinds of pain. an acute gout inflammation, this person probably can't walk and their big toe will be swollen like this. The culprit here, the little crystals, are called monosodium urate. Monosodium urate. And it's a crystallized form of uric acid, which is something that is normally in our body as a byproduct, a breakdown product of our DNA and RNA. But when for some reason there's too much of this, it crystallizes and as it goes around our body, it gets stuck in this joint. And whatever joint it's stuck in is going to be painful and cause gout, but more often than not, it's here. And by the way, gout in the big toe is so common, it actually has its own name called podagra. Podagra. The group of people that most often get gout, if we're trying to look at statistics, it's going to be males and usually a little older, on the older side. So I would say 50 plus. Some people say it has to do with lifestyle, and one of the treatments for gout is lifestyle changes. But on a pathophysiology level, anything that increases uric acid is likely to lead to symptoms of gout. So in terms of symptoms, we have a lot of pain, especially in an acute flare. And if we look at it, it will look red, which we call erythema. It's red. It's swollen. And even though we think of it as a joint disease, this metatarsal joint, but the deposition is actually also in the surrounding tissues as well. And this intense inflammation here will also cause the area to feel hot to the touch. So the symptoms and the history should give a lot of good clues for diagnosis, but to formally diagnose it, with a gold standard test, we can take some of the fluid in the joint space and analyze it. And diagnostic of gout is to find these needles. When we look at it under polarized light, they're going to be negatively birefringent. Birefringent. So that's a lot of physics that I don't understand. But I know that what they mean by negative birefringence is that if they're laying flat, if the needles are laying flat, it's going to be a yellow color. And this will be helpful later on when we talk about distinguishing gout from pseudogout. These particular needles made of monosodium urate will, as a rule, when laid flat with the polarized light on it, it's going to look yellow. So that's the synovial joint fluid, but we can also take some blood. And in people who have chronic gout, or even just more likely to get gout, we'll probably see hyperuricemia, which is going to lead to more uric acid. This is a direct evaluation of uric acid. It can not only tell us this person has or is likely to get gout, but as we treat them, we can use this to track how effective the treatment is. We can also get a white blood cell count and a erythrocyte sedimentation rate, which is measuring how fast the red blood cells become sediment, but these are really inflammation markers. This one is a marker of inflammation, and this one is a marker of how active our immune system is. So both of these can actually go up even without an infection. White blood cell we think of as a marker for an infection, even though this is not an infection because these uric crystals are not bacteria, they're not pathogen, but the immune system it elicits can make these numbers go up as well. So even though the history can be very characteristic of gout, we want to do these tests to distinguish it from other things it could be, like infectious arthritis, or the autoimmune things that you really don't want to miss, because the treatment for gout can be very specific. First, there's going to be the non-specific treatments. We want to deal with the pain, so NSAIDs, which also actually decrease the inflammation. So NSAIDs and possibly stronger things if they cannot tolerate NSAIDs or if the pain is too great. And then we want to decrease the inflammation. These are not specific. You can use these in a lot of autoimmune type diseases. And here we can use steroid injections, among other things. But in gout, actually the first thing they should do is to have a lifestyle change. There is a genetic component to gout, but there's also a lifestyle component. And it's actually hard.
Issues applied in Ecuador. In Ecuador, there are no statistical data on the national prevalence of gout, nor are there any related research to the nutritional profile of patients with this gouty disease. However, the excess nutritional disorders like overweight and obesity are reported as a major health problem. According to the Ecuadorian sources of the Ministry of Public Health, 43% of the country's adult population is on overweight, while obesity affects only the 33% of the population of the last 15 years of age. These figures for the child and adolescents are also worrying. Considering the high prevalence of nutritional disorders in Ecuador, the influence they exert on the appearance of gout in diseases in crisis, and the lack of studies that help identify nutritional pattern on patients with gout. If it's to decide to carry out this research to identify nutritional pattern on patients with gout treated at the hospital nutrition consultation and DNF Chimborazo. A conclusion: clinically diverse related and particularly matter-related disorders are known now to share molecular pathogenic mechanisms such as necroinflammation driven by the NLRP3, caspase-1, caspase-11, interleukin-1, or by RIPK1 and RIPK3, and MLKL. Since therapeutic blockade of interleukin-1 has reached the clinic for the treatment of gout, there is an increasing hope that some of the other evolving drug molecular targets will also eventually become innovative cures for patients with diseases related to the crystals, particulate matter, or misfolded proteins. Thank you very much.